Hi, everybody, and thanks for joining us. My name is Dan Gorenstein. I'm the founder and executive editor of Tradeoffs. If you're new to Tradeoffs, we're a nonprofit newsroom that covers healthcare's toughest choices. We produce a weekly podcast called Tradeoffs, which you can get wherever you listen to your podcasts. All year, health policy change under the Trump administration and the Republican Congress has been swift, and it has been massive in scope. It can be hard to make sense, let alone assess the consequences of the news. That's why we are partnering with our friends at the Leonard Institute of Health Economics at the University of Pennsylvania for a series of conversations called Decoding the Moment.
And I am Rachel Werner. I'm the executive director of LDI. LDI is Penn's hub of research on healthcare delivery, health policy, and population health. We bring together over 500 researchers who are national experts and thought leaders in this area. We're coming together with Tradeoffs to create a place where you all can better understand what's happening in Washington and what it may mean for the future.
And the biggest news in Washington right now in health policy is that the federal government is set to shut down in 6 days, as many of you know, and Congress is at this stalemate. In exchange for their votes to keep the government open, Democrats are pushing to extend so-called enhanced federal health insurance subsidies.
And the Democrats say these subsidies, which are set to expire at the end of this year, are critical in helping millions of people pay for their Obamacare coverage. Republicans, on the other hand, say these subsidies have fueled fraud and are too costly. Congressional analysts say that keeping them in place would cost an estimated $350 billion over the next decade.
Today, we want to help you push past the partisanship and understand the evidence around these subsidies and the trade-offs of other ways of providing coverage at lower costs. We've asked for your questions in advance, and more than 70 of you submitted them with your registration. Thank you so much for that. And please talk up the other folks who are in this chat. We hope that part of what can happen in today's conversation and through all of these events is to help you all be connected and to learn from each other. To initiate that, please jump into the chat right now, introduce yourself, and maybe what you were hoping to learn today. And while you do that, I'm going to turn it back over to you, Rachel, to kick off this conversation with 3 big numbers.
All right, thanks, Dan. So to help ground today's conversation, I have 3 numbers, as you said, and these provide an entry point to what the subsidies are and the role that they help play in providing health coverage in America. So the first number is 24 million. That is the number of people who are currently enrolled in Obamacare coverage, meaning that they have bought their insurance through a marketplace that was set up as part of the Affordable Care Act. By 2019, the marketplace coverage provided health insurance to about 12 million people, many of whom received help in paying for their insurance through tax subsidies or premium tax credits. Then, with the COVID-19 pandemic, Congress expanded these premium tax credits to more low-income Americans. And with these enhanced subsidies, enrollment in Obamacare surged, adding another 12 million people to coverage. And that brings us to the 24 million people who are enrolled today, of whom about 93% rely on subsidies to make their insurance premiums affordable. So the second number is $10. $10 is the amount that 80% of people pay per month through Obamacare. So with the help of enhanced subsidies, it's reduced the cost of this insurance option to $10 or less a month. And before subsidies, that number was much lower. It was only 36%. And so who are the individuals who are insured through Obamacare? That brings me to the third number, 48%, which is the percentage of adults getting their health insurance through Obamacare who are part of a small business. So nearly half of those people who are getting health insurance coverage through Obamacare are small business owners, employees, or self-employed. And this is a group who otherwise might not have access to affordable health insurance options. Back to you, Dan.
Thanks a lot, Rachel. Thanks for those numbers. And hopefully those numbers give everybody a little bit of context so we can begin to understand the stakes of what we're talking about as Congress debates what to do about whether to extend these tax credits or not. I'd like to turn to our panelists. I'm very excited about this. We have 2 of the country's preeminent experts on health insurance with us today. I'm going to ask them to briefly introduce themselves. Kate, would you please go first?
Hi, I'm Kate Baicker. I'm a health economist at the University of Chicago, and I wear several different hats, but I'm speaking only for myself and getting to be a health economist for the hour. So thank you for having me.
Thanks. And John, if you'd introduce yourself too, please.
Sure. My name is John Gruber. I'm the chairman of the economics department at MIT, and I get to still be a health economist. I don't have to stop it to be provost or anything like that.
Very good.
Lucky
And
man.
And so, you know, the first couple of questions, I say this to the audience to just orient you all. These first couple of questions are just sort of some table setting questions to give everybody some context to make sure we all sort of understand where we are and what we're really talking about right now. So, John, this first question to you, you advised the Obama administration on the creation of the ACA after helping then Massachusetts Governor Mitt Romney create so-called Romney Care. In a nutshell, sort of mechanically speaking, why were subsidies included in the first place? What is the purpose that they serve?
Basically, I think it's good to just go through the history of how we got here. So basically, how we got here is we had a broken non-group insurance market where individuals couldn't get insurance for fair prices, particularly if they were sick. The view was that should be fixed by guaranteeing what we call community rating, which is everyone gets the same price, sick or healthy, and no exclusions of pre-existing conditions. That's very popular. The problem is if you do that by itself, insurers leave the market. That's what happened in 7 states, including Massachusetts, because they're afraid that they can't discriminate and people can still buy insurance only when they need it. So for that reason, to make sure insurers are willing to participate, you need a mandate. You need a mandate to make sure that employers actually want to stay in the market, that people have to buy insurance so insurers can know that they can make a profit at a fair price. But you can't mandate people buy something they can't afford. So that led to what I call the third leg of the stool, which is subsidies to make health insurance affordable. In Massachusetts, these were discounted price of insurance. At the federal level, it's both an expansion of Medicaid and tax credits towards buying insurance on the exchange.
Great. Thank you. So we have these original subsidies. And then in 2021, as Rachel alluded to, Democrats and the Biden administration expanded them. Previously, you could only get these subsidies if you made less than 400% of the federal poverty limit. That's a little over $100,000 for a family of 3 in today's dollars. Now, under these enhanced subsidies, anyone could get them, and Congress made them more generous. These enhanced subsidies are what are going to expire if Congress does not act. Now, U.S. taxpayers have spent more than $20 billion on this additional aid in 2023 and 2024. That's according to Kaiser Family Foundation, or what is now called KFF. Congressional analysts estimate it would cost another $350 billion to keep these around for another decade. John, based on the evidence that we have, what have we gotten for all that money for those? What has that $20 billion bought us in the form of these enhanced subsidies?
Yeah, Dan, let's just once again, one bit of background. So the way it was set up, the ACA was you get a tax credit to offset the cost of your insurance. That tax credit is set so that you pay a certain amount of your income towards insurance. The idea was right when you're just eligible, which was at 133% of the poverty line, you paid about 2% of your income for insurance. And it ramped up so that by 4 times the poverty line, you paid originally got to about 10% of your income for insurance. And then above that, subsidies were gone. You paid the full price. That had the problem that many people were at 4 times poverty spending 20 or 30% of their income on health insurance. Consider the 55-year-old in New York State. Insurance for that person was something like $15,000, something very expensive. That was unaffordable even at 4 times the poverty line. So the idea was to get rid of that notch and also to make it more affordable along the way. And that's what the subsidies did. I have a recent paper with Benjamin Summers and Gabby Afendoulis, who were at the Harvard School of Public Health, where we actually estimated the effect that these subsidies had on individuals. And we estimated that getting rid of these subsidies would cause about 3.7 million more people to lose health insurance. That's pretty much in line with what CBO is saying, is the effect of getting rid of these subsidies. So I think the big effect is a lot of people lose insurance. The second big effect is a lot of people will pay a lot more for their insurance. And even those
Wait, hold on, John. I'm going to interrupt you here because you're answering what we would lose, and maybe it's just the converse. But what did we spent $20 billion?
Oh, I see. What do we get?
20. What did we? Because what I'm hearing you say is that we bought millions of Americans more access to insurance. That is what we bought. What else did we buy other than giving these people more affordable insurance? Or is that all?
We essentially bought the ability of people. It was called the Affordable Care Act, after all. We bought people the ability to afford insurance. I'd say the most important thing we bought, Dan, is we could now make a statement that no American has to pay more than 8% of their income to buy health insurance, to buy good quality health insurance. That it was in some sense a social compact guarantee we gained, where we said, look, it's not like you have to pay this unless your income's above this, then you have to pay that. It's like, look, you'll pay more as your income goes up, but no American is gonna have to pay more than 8% of their income to get good quality health insurance. I think that was the main thing we gained, was a level of social protection, a guarantee. Along the way, that brought millions of people into the exchanges and millions of people into insurance coverage. And that's a wonderful benefit. But to my mind, the biggest benefit is the power of that statement, which is to say we are going to be a country where we're going to make sure people can get health insurance for 8% of their income.
And one final question on what else we bought. I appreciate this point about like this is this sort of statement we're making, this social contract that we're saying to people, hey, insurance is going to be affordable to you.
Yes.
That is what we bought. So I know it's early here, but any positive health effects that we have gleaned yet from 2023, 2024 as a result of the enhanced subsidies? Or we don't know that? We don't know that.
I don't know of any good studies of that yet.
Okay, great. Thank you. And I think that I think it's pretty clear, you were beginning to get into what we risk losing if these subsidies go away. Let me just say this to make sure for folks in the audience. Experts estimate anywhere from 2 to 5 million people could end up uninsured starting next year if this goes away. Out-of-pocket premium payments for those still buying Obamacare coverage could jump more than 75% on average. We have two folks in the audience, and I might be mispronouncing your names. If I do, I apologize in advance. Heather Bednarek and Rithru Ramachandran in the audience want to know, John, what we would expect the health impacts to be if these subsidies go away and millions of people end up uninsured. So what are the health impacts?
Yeah. So look, we should talk more about the evidence, but I think the best evidence comes from studies that have been done of what the Affordable Care Act did. There's really high quality studies of both what the Medicaid expansions did, which show they saved lives, and studies of what mandating private insurance did, which came from this really cool study where people randomly got reminders about their mandate and picked up insurance. Both of those studies show that when people lose insurance, they die. Now, not one for one, obviously, but the best estimates are something like for every 500, 800 people who lose health insurance, one person dies. So if we're talking about 3.7 million, if in the upper limit we're talking about 5 million people losing health insurance, then basically we're talking about 5,000 people dying a year more because they've lost that health insurance. Now that's an upper bound. Maybe it's 2,000 at the lower bound. The bottom line is that thousands of people will die because we're moving this health insurance coverage.
Thanks, John, for that. I'd like to bring you and Kate here to talk more about the evidence. Earlier this year, Tradeoffs did a story about why many Republicans wanted to shrink Medicaid. And something that came up for us, Kate, again and again, as we interviewed conservatives, was their belief that there's limited evidence that having health insurance actually improves people's health. And a number of them cited your work, your incredibly influential study, the Oregon Medicaid experiment. And for context, I know you know what that is, but for the crowd, that was a big randomized controlled trial in the early 2000s. It compared people who got Medicaid coverage in a lottery with those who did not. And you found no differences between the two groups in 3 physical health outcomes that you measured: cholesterol levels, blood pressure, and keeping diabetes under control. Since then, as John has just explained, several studies have found that Medicaid and expanded coverage under the ACA have improved health and even saved lives. Kate, please help us make sense of this. Of all the folks I've talked to over the 10 plus years I've been a healthcare reporter, you are one of the most honest brokers I know. What is take that for what it's worth, which might not be much. What is your honest reading of what we know about the impact of health insurance, including on mortality? Because different people are out there drawing different conclusions.
Absolutely. And I really appreciate the opportunity to talk about the nuance of the evidence, because health insurance does lots of things to healthcare use, and health is a multifaceted outcome. So different studies are giving us different pieces of the picture, and different studies bring different strengths. And the reading of the evidence overall, I think, paints a very compelling picture that health insurance is very good for your health in multiple different ways. It is not, Medicaid itself does not cure high blood pressure. It doesn't manage chronic physical health conditions any better than lots of other insurance products that we have. But there's no question in my mind that people with Medicaid are much better off than those without it. And people with any insurance are much better off than those without it. They have better access to healthcare. They're more likely to report their healthcare needs are met. One thing we found in the Oregon study was that there was a dramatic drop in depression, which is in and of itself a large unmet health need, but also then correlates to lots of other downstream health outcomes. We did not, in the Oregon study, which John collaborated on part of, it's a very interlocked group of health economists in the world, we did not find any effect on mortality, nor did we expect to, which doesn't mean that there was no effect on mortality. It means that mortality in this prime age population we studied, which in that study was 19 to 64-year-olds, is mercifully relatively low. So you need a giant sample size to be able to detect effects on mortality. Oregon was never powered up. We didn't have a big enough sample size to be able to say anything useful about mortality. Somewhere between no one and everyone died. And that's not helpful evidence, and we wouldn't point to that one way or the other. I think people are correct to say we did not find any effects on high blood pressure, any effects on HbA1c or diabetic blood sugar control, any effects on obesity, any effects on cholesterol. That doesn't mean there were no effects on health. Now, I've worked on other studies, including with Ben Summers, see prior point on interlocked researchers, that used states that chose to expand Medicaid in advance of the ACA expansion versus those that didn't, to get much bigger sample sizes to look at mortality among millions of people in before and after expansion in states that did and did not expand. And there we did find mortality effects. Other colleagues here at the University of Chicago and Dartmouth have a recent study looking at mortality that found meaningful mortality effects. It's just mortality is a relatively rare outcome. So it takes a giant sample size, and the effects are, you might look at the effects John described and say, oh, those are modest in size. Mortality is a really important outcome. So even small changes in that, I think, are obviously, incredibly important to those people and to their families. So I wouldn't discount the outcome just because it's relatively rare. The last point that I'd like to make on the evidence, though, is all of this is talking about the benefits of health insurance. To me, it seems clear there are important, big health benefits to people who get insurance. Those benefits aren't free. They have to be weighed against the cost of expanding the insurance. People use more healthcare, and someone has to pay for that. And for our public insurance programs, the taxpayers who pay for it may be different from the people who are enrolled in the program. And so the question for policymakers and for voters is, how much do you value this bundle of health improvements for this population that gains insurance through the program? Is it worth the cost to finance the program? And what is that value relative to spending that money on education or housing or food or anything else, lower tax rates? anything else you might use those resources for. So as a policymaker and as a voter, you don't want to think about just the benefits. You want to think about the costs and decide what's important to you as a society.
Kate, just one final question about this evidence that I'd like to hit on, and just hitting on it as quickly as we can. There was a time when you were less certain about the positive health benefits of insurance. If you were to try to pinpoint it, I don't mean just one thing, and I know it's the accumulation, it's the preponderance of evidence that has happened over these years, but can you just, because this is such a hot button debate among health policy wonks across the political spectrum, why did your opinion go from being less sure to being more sure about these positive health benefits of insurance?
Oh, you said, yeah, I know it's not just the accumulation of the evidence, but it really is just the accumulation of the evidence. I think this is a harder question to answer without good evidence than you might think. I think it's easy to say, well, of course insurance is good for your health. Of course healthcare is good for your health. But as, empiricists and, data-driven social scientists, we're disposed and trained to say, show me evidence about what the causal effects of insurance are. And before you have really good causal evidence, whether it's an experiment that has, really good causal internal validity, whether it's a quasi-experiment that gives you bigger sample sizes and better generalizability, when you put all the pieces together, you want to be able to say, changing insurance has this effect. And without that robust empirical strategy, people with insurance are very different from people without insurance in lots of ways. And saying people with insurance live longer, well, they also tend to be higher income. And maybe it's the income. Maybe it has nothing to do with the insurance. Maybe it's that they live in different neighborhoods. Maybe it's that they have better education. Who knows what cause and effect is until you have a robust set of evidence. I think from before the ACA, Oregon study, state expansions, then with the ACA, where you see a sharp break over time and sharp cutoffs in who's eligible to stay on their parents' insurance and all of these different changes in policy, that generated a lot of evidence for all of us that I think speaks pretty clearly to the benefits of insurance. And again, then policymakers and voters have to weigh those benefits against the cost. But I learned from the evidence, as I hope everyone on the call did.
Thanks, Kate. And John, I know you want to jump in, but I'm
Yeah.
not going to let you. I'm not going to let
Okay.
you. We're going to get to this next question here, sir. So the best form of insurance and how much we should spend on that, obviously, as you've painted, you've portrayed, Kate, is up for debate. We are seeing folks in the chat ask questions about whether there are better, more cost-effective options than these pretty expensive subsidies. We're now in a moment where the GOP is shrinking what we spend on healthcare. The so-called big, beautiful bill from this summer cut $1 trillion over the next decade, mostly for Medicaid. Obviously, letting these subsidies lapse wouldn't continue that trend. For years, we've seen Republicans push for more access to so-called skinny plans, health insurance that costs less and covers less. This includes so-called short-term plans and association health plans. Sorry for that siren in the background. It's always crazy out here in West Philly, as well as options that include more out-of-pocket spending for consumers. For example, the Trump administration just recently made it easier for people to buy what are known as catastrophic plans with high deductibles. The question for both of you, and John, we'll go to you first. What does the evidence tell us about the health effects of these skinnier plans that cost less and cover less?
Dan, it's a great question, and I think we need to think about what skinny means. I think that basically here is where I think the debate is misleading. Okay, or else I keep backing up on your questions, but here's the debate.
I love it. It's great context. You're good context.
In some sense, I think people don't understand what skinny means. So certainly you can define skinny in terms of how big your deductible is. Plans can be skinnier or fatter based on how big the deductible is. You can have a $10,000 deductible. That's a very skinny plan, or a $0 deductible. That's not skinny. But in terms of what the plan's actually covered, there's not a lot of disagreement. Basically, you got to cover drugs, you got to cover inpatient, you got to cover outpatient, you got to cover doctors. You do that, there's just not a lot else. I mean, yeah, maybe you don't cover plastic surgery. Maybe you don't cover certain specific drugs. Maybe you don't cover GLP-1s, like Ozempic. But at the end of the day, we're talking single-digit percentage differences. We're not talking, there's not a plan out there, and Kate may disagree on this. I'd love to hear your view on this. I do not think there's a plan that exists that is meaningfully called insurance, where at the same cost sharing, it's more than 20% less than any other plan. It
And let
basically
me
is
jump
all
in
about
with one
cost sharing.
thing. John, I agree with what you're saying, and let me jump in with one clarification. There have been periods where people have been more enthusiastic about plans that have a lot of upper limits on catastrophic coverage, where, they cover up to X thousand dollars of care. I think John and I would both agree that's bad insurance. Insurance is supposed to protect you against big unexpected expenses that you can't afford otherwise. An insurance plan that caps benefits at $1,000 or $10,000, those are sometimes called skinny plans. I would call those like prepaid healthcare that has very little insurance value. Those are worse. And that's not, I think, what we're talking about here, because the catastrophic insurance protection is in some ways the most important part of the insurance aspect of insurance. And it's also the part that is sometimes hard for people to appreciate, because if you have health insurance and you're very healthy and you don't use a lot of benefits, you may think, those protections weren't worth anything, but they were worth a lot. You were lucky that you were healthy and didn't need the high-end coverage of things. That's what insurance is for, when something bad happens, to protect you from the financial consequences of the bad thing. Sorry, John, go ahead.
It's super well put, Kate. I think the bottom line we're agreeing, Dan, is skinny versus not skinny is not about the benefits you cover. It's about the cost-sharing provisions, either the deductible or the cap. That's what drives. So then, to answer your question of what do we know about skinny versus, come to your question. We keep ignoring your questions. Let's come to your question. What do we know about skinny versus non-skinny? What we know really comes from the evidence. What do we know about high deductible versus non-deductible plans? That's the relevant question. And the answer here is quite mixed. I think I would summarize the evidence as saying when people face more cost sharing, on the one hand, they use less of everything, including both valuable and less valuable care. On the other hand, there's not a lot of evidence they're in worse health. So it's sort of this weird thing, which is how can they be using less valuable care and not be in worse health? And there's two possible answers. One is doctors are wrong about what care is valuable. That kind of valuable is some doctor's definition. The other is that, remember, people choose their plans and choose how to react. That maybe the set of people who cut back care are exactly the set of people who don't need that care. And then it's also, you need the care, you still get it. If you don't get the care, you don't. So maybe that's how we can get this weird outcome that on average, you're seeing that valuable care falls, but in fact, you're not seeing overall negative health effects of these high deductible plans.
Now, I think cost sharing in some ways gets a bad rap because people focus on the cost shifting aspects of it. I think people sometimes perceive high deductible plans as just making individuals bear more of the risk versus employers bearing the risk. And I don't think that's quite the right way to think about it. First of all, you can have a high deductible plan and a health savings account that matches what the deductible is, and it can have the same net exposure to costs for people. Now, that's not always how it is. The high deductible plans don't always come with funded health savings accounts, but the high deductible in and of itself comes with a lower premium and then the possibility of the savings account being fully funded. So it's not the deductible itself that lowers the value of the plan to people. It's what else goes with it. And the goal of having cost sharing could be to help people focus their resources on the care that actually improves their health the most. And if people were perfectly farsighted, rational agents, there's a lot to be said for that, where having some cost sharing or having it come out of your health savings account versus some pool that you don't have any control over might deter use of care that's of questionable health benefit. And we know there's a lot of care out there that has pretty minimal effect on your health. But I agree with John's reading of the evidence that, in fact, when people face higher copayments, they cut back on valuable care as well as less valuable care. So I would love to have us move into a world where the co-payments that people faced reflected the health value of the care. And you face a higher copayment when the care was of questionable medical benefit to you, and a lower copayment when it was a very high benefit. And then we get to the really thorny question that John alluded to of who's deciding what's of high benefit or not. And it's not clear that even medical professionals are unified about what healthcare is of high health benefit or not.
And do you all in your, as you all study this and follow it closely, when you look at sort of Republican proposals that are aimed at thinking about health insurance differently, these sort of skinnier plans, do you see Republicans looking for a way to sort of ultimately, I guess, lower the floor so that there's more out-of-pocket exposure and that the government's willing to guarantee, the government's willing to cover less and that the individual must cover more? Is that how you sort of generally understand the more conservative thinking about this?
I think basically, once again, the more conservative thinking is a talking point that, oh, the miracle cure here will be skinny plans. But they don't talk about what's skinny. And as we said, skinny comes from either paying more upfront or being capped in the back end. Capped in the back end is never a good idea because then it's not insurance, as Kate so nicely laid out. More upfront, there's a trade-off. We've talked about that, but it's not this magic cure they've laid it out to be. And I think people, you name your podcast as trade-offs, and I think the inherent trade-off people have the hardest time understanding with healthcare is the premium out-of-pocket trade-off. That basically, if you want to make it skinny by making people pay more out of pocket, you can have lower premiums, but then people can pay more out of pocket. People want both. They want both low premiums and no deductible, and you can't have both.
And it's worth noting that when you get your health insurance plan from your employer, you're still paying the premium in one way or another as an employee. That I think people imagine somehow that the share that the employer pays is not affecting them. But there's a pretty good evidence base suggesting that when healthcare gets more expensive and premiums go up, even if the employer writes the check for the premium, it still comes out of employees' wages in that wages rise more slowly. There's an amount of total compensation that an employer is going to pay for an employee. And if more of it goes to health insurance, less of it is available for wages or retirement benefits or other fringe benefits that the employee might value. So people bear the cost of rising health insurance premiums, whether they're the ones writing the check or not.
As we talk about sort of setting the floor, it opens up, in my mind at least, the opportunity to think a little more dynamically about health insurance. We've got a question from Kate Barber in the audience that hits on this. And Kate asks, quote, what is a more sensible way to cover health insurance for more people? Kate Baicker, you've thought a lot about this. You co-authored a paper in 2023 that laid out a proposal that in some ways combines this historically conservative idea of a skinny plan with the more progressive goal of universal coverage. Can you, again, briefly sort of explain the proposal?
Sure. And it turns out, Amy Finkelstein and I were key principal investigators on the Oregon project. We have our own research projects as well, and we both arrived at a similar idea. And a similar idea is laid out very nicely in Amy's book. But
yeah, we've got you covered, her book. Yeah.
There you go. But the way that I framed this with co-authors, including Mark Shepard, John Skinner, Amitabh Chandra, is thinking about something that's more like Medicaid for all than Medicare for all, which is coming to agreement as body politic on what we think the minimum coverage should be for everyone in the country. Establishing public insurance that covers that minimum bundle, whatever that is, and then letting people top up with more generous insurance that covers more stuff if they so choose. Now, what do I mean by minimum bundle? John laid out sort of big categories that almost every insurance plan currently covers. I would be interested in having a public plan that had coverage determined by the health value of the services. We spend a lot of money on healthcare that is of marginal benefit. It's not, yes, we're all against waste, fraud, and abuse. We should eliminate waste, fraud, and abuse. That doesn't get you very far. There's a lot of care that has positive benefit, but at a very high price. And my concern is that I don't think that public insurance can cover very expensive care with very limited health benefits for everyone and not spend 100% of GDP on it. So think about what could be covered based on the value of health produced for every dollar spent, and have a floor for that, that everything above that floor is covered for all people, and everything else is only available if you buy supplemental coverage. Again, we get to the 30 question of who determines what the floor is, but there is plenty of expensive healthcare that is worth every penny, that cures diseases, that saves lives. There's plenty of cheap care that does very little good. So it's not just about the cost of the care, it's about the health value of the care.
Thanks, Kate. John, I know, and I just flagging time, we've got about 8 minutes, 7 minutes left. John, this is not, you are somewhat skeptical of plans like Amy's and Kate's. Can you, but at the same time, you talked at the top of our conversation, you said that for the $20 billion that we spent on these enhanced subsidies, we're kind of like making this statement. We're telling everybody you should be able to buy health insurance at an affordable way. At an affordable price. And obviously Kate's plan, this universal coverage plan, is trying to achieve a similar goal. What's the skepticism, dude?
So I think the skepticism is not at all of what Kate laid out. So there's two forms of skepticism. There's economic skepticism and political skepticism. Kate, I didn't read Kate's article closely. I've seen Amy's book. I know Amy at least says, look, I'm not dealing with the politics. And maybe Kate says that too. The political stuff we'll put aside. Economically, I love what Kate's laying out. What I don't like is what I've read elsewhere. I don't think this is as explicit in Amy's book, for example, which is that the package will be defined by a value-based criteria as opposed to by the specific nature. So for example, I think do you cover surgery as part of your package? Well, you sort of have to. Kate would go further and say, no, only surgeries that have a value above their cost. I think if you could carry that out, then I totally am in favor of that. I think it would save a lot of money. I was reacting more to what I took Amy's book, which was more just like, look, we'll just have a skinny plan and it'll cover less stuff. And I think that's just not realistic. But I think what Kate laid out is fine. And maybe I misread that in Amy's book. Maybe that was Amy's proposal as well. But I think the bottom line is, if you truly are going to do the European strategy of saying we're going to have a true social valuation exercise and only covers things that pass a true social valuation benchmark, then I think you could save real money without endangering health. Politically,
and I do think this is a difference between the approach that I'm talking about and maybe what was captured in Amy's book. So I do think there's a little difference there that John is pointing to. But one thing that I think is a really important criticism is, who's deciding social value? How are you measuring it? And
well, Kate, I thought it was
article is not a blueprint for here's exactly how you would do this. It lays out in concept, here is what a high value universal public plan could look like. But there would be a lot of work to be done to get there. And I, like John and Amy and most of our co-authors, am not a politician and wouldn't dare to say how this should actually work its way through a political process.
But the germ of the idea, Kate, is that if we could start all over, if our country could start all over again, getting a body together, and I understand the difficulties of who's this body, who's making the decision, but the simple idea for the audience to follow along is that you get a body together that decides what is going to be part of the guarantee, part of the floor of the insurance plan.
Yeah, and I think we're much closer to being able to do that conceptually than we used to be, because I think we have much better data than we used to and much better ability to tailor those recommendations based on individual circumstances. One of the challenges is most healthcare is not high value or low value uniformly. It's not like MRIs are good or MRIs are bad. They're good in some circumstances, absolutely worth it, and contraindicated in other circumstances, actually harmful. And so the coverage couldn't be, yes, we cover MRIs, or no, we don't cover MRIs. It would have to be much more nuanced than that. And so that requires a lot more data to be able to make robust recommendations. But the good news is I think we have that, or we're much closer to having that. And one other point to make when
yeah, and very, very quick here, very quick, Kate, because I've got two more questions I both want to give you guys time for.
The quick point is that European countries with universal health insurance are not so universal after all. There are lots of countries where high-income people top up their plans or go around queues. So what we're talking about is not so unique.
Thank you. Let's bring this back to the debate in Congress over the enhanced subsidies. And both of you guys, super short answers here because I want to make sure we give Rachel Werner a second at the end. John, several people in the audience, including Meryl Guzner, Gina Krupp, and Matt Klebanoff, asked if states can do anything to mitigate the impact of these enhanced subsidies expiring. You've published a working paper earlier this year that offers some useful insights. What did you find? And again, please be brief.
Basically, the key insight is states play a big role. We found that states that run their own exchanges have much more effective implementation of the ACA than states that don't. I think states can play a large role through outreach and through other tools to facilitate enrollment in the exchanges and to try to mitigate the damage done by these subsidies going away.
So if this enhanced subsidies go away, states actually have some control. If states are really concerned about this, there are actions they can take.
There are actions they can take, in particular actions they can take to facilitate enrollment and advertise enrollment. They're not going to solve the problem, but they will help on the margins.
Kate, as we've said, Congress is unlikely to start debating a version of your plan for universal coverage, but Republicans are focused on cutting federal health spending and promoting health insurance options that cover less. What do you want conservative policymakers to be thinking about as they consider these changes to health insurance? Like, what trade-offs are they actually making if they go ahead and let these enhanced subsidies lapse?
I think we've outlined them in the conversation that there are real health benefits to people of having insurance that gives them access to care that they wouldn't otherwise have. And that comes with a cost. The healthcare use has to be paid for. These plans don't pay for themselves. So I would ask policymakers to be weighing the costs against the benefits and thinking about the alternative uses of the resources, and would you do as much good spending those resources somewhere else? And those are hard questions, but I think we have a lot of evidence of the benefits of insurance coverage.
Very good. That is, I want to, just before we bring Rachel in here, but Rachel, feel free to turn on your camera. John, Kate, it has been an absolute joy and pleasure to talk with you both. Thank you so very, very much for this robust, important, nuanced conversation. Thank you.
And I'll just add my thanks to both of you for participating in today's discussion. It was a great start to a really important topic. It was just the beginning though. So for those of you who are interested in digging in more, please look out for our post-event email, which will include links to further readings on both the Tradeoffs and the LDI's website, where we have published additional information about today's topic. In addition, you see in the chat a link to a survey that will also be in the email you receive. Please give us feedback on how we did today, what we could do better, and we can take that into account as we plan our next Decoding the Moment event. And please be sure to join us for LDI's next virtual event, which will be on food policy, looking at opportunities to build a healthier America through food policy. And that will be on October 17th at noon. So thank you, Dan. Thanks, John and Kate. And it was good seeing all of you here today.
Thank you so much.
Bye.
Thank you. Bye-bye.